Hello, and welcome to the first presentation we're going to do for the Haematology Academy, which is on anemia and interpretation of a full blood count. My name is Dr. David Tucker. I'm one of the consultant haematologists here at Royal Cornwall Hospital Trust, and together with Dr. Everden, our research fellow, and Dr. Challoner, our registrar in haematology, we've put together a few slides to help you interpret a full blood count. So this is the kind of thing that you get back when you ask for a full blood count from the laboratory. You get presented with the white cell count, the hemoglobin, which is the number of red cells or a function of the number of red blood cells in the sample, the platelet count, the red blood cell count or the number of red blood cells in the sample, hematocrit, which is the amount of the sample which is taken up with red blood cells when the sample is spun down or allowed to settle. So the red blood cells settle to the bottom, and then the plasma is above that, and in between that is a small layer called the buffy coat, which contains the white cells and the platelets. And the hematocrit is expressed usually as a percentage of 1. So for example, this sample, which is particularly low and particularly anemic, it's 0.19 or 19.4%. And we would normally look at a hematocrit of around about 36 to 44% or 0.36 to 0.44. It gives you the mean cell volume and the mean cell hemoglobin. So that's the amount of hemoglobin in each cell and the size of each cell. And then the MCHC, which we don't use so much in clinical hematology these days. And then it gives you the white cell differential. So the white count is divided. The white blood cells are divided into granulocytes, which are your neutrophils, your eosinophils, and your basophils. Your monocytes, which are also phagocytic cells in the blood from the myeloid lineage, and then your lymphocytes, which are your lymphoid cells. This is a particularly anemic sample. Actually, this is a sample of pancytopenia. The platelets are low, the hemoglobin's low, the white cells are low, and this is because of this particular patient has had chemotherapy. But the numbers are sometimes shown in a red or a different color if they're abnormal, and black if they're normal. So I've just circled there the things that we'll be concentrating on in this particular presentation, which is the red cells and the red cell indices. The red cells are accounted for by the hemoglobin. The hemoglobin is the concentration of hemoglobin in that particular sample. And then the red cells indices are the red blood cell count, the percentage of red cells in the sample, the mean cell volume, and the mean cell hemoglobin are the main things there. Okay, so we're going to look at the red cells. So red cells are made in the bone marrow, and their role in the blood is to mainly carrying oxygen and carbon dioxide. They are gas transfer cells, really, which is why they have a high surface area to volume ratio, because you want lots of surface area for them to be able to move gases in and out, and you don't want compared to their actual volume. And red cells in the blood have got no nucleus. They lose their nucleus in the later stages of their development in the bone marrow. This is to make room for as much hemoglobin as possible. And as the cell is developing in the bone marrow, it requires various stimulants and signals to make it mature and grow. And one of those is something called erythropoietin, which is made by the kidneys, of course, and is made in response to low red cells or low oxygen levels. And then another one is a growth factor called CSF, colony stimulating factor, or that can help to stimulate red cell production. And then there are key substrates or molecules that we need to make red cells: iron, vitamin B12, and folic acid. So you need all of that, and you need a healthy bone marrow to make red blood cells. And then once they're made, they're pushed out of the bone marrow and into the circulation. Just beforehand, they become what's called a reticulocyte. Reticulocytes are baby red blood cells. They're called that because they have this network of nucleic acid, which is still just finishing off making hemoglobin before they're eventually fully hemoglobinized. And so we sometimes measure the reticulocyte count in the blood. It's a sign that the bone marrow is responding to whatever is causing them to be anemic, and it's also a sign that the bone marrow is healthy. So yeah, so that's your red cell production, and then once the red cells are made, they last about 120 days in circulation, although that can be shortened if the patient is particularly unwell. Before that, they are recycled in the liver and spleen. The components are removed and then returned to the bone marrow. So the red cell is a really interesting cell because it has a very, very sophisticated membrane made up of this skeleton of various proteins, actins and spectrins, and a phospholipid membrane here, which allows it not only to transfer gases in and out, but also maintain that beautiful biconcave shape. So it has a thin area in the middle, which is seen here on this blood film. Thin area in the middle, not much hemoglobin there. Thicker areas like a rubber tire on the outside, plenty of hemoglobin there. And that's a normal classical red blood cell. You can tell it's normal because the pale area in the middle makes up only about a third, with the other 2/3 being made up by the thicker areas. That tells you that this is a normal healthy blood cell, and these are all pretty much the same, they're uniform. This is a platelet, by the way, as seen here on this film, and this is a white blood cell here, which you can't see any white blood cells on this film. The other thing to know about the red blood cell membrane is that it can do what's called tank treading, so it can roll over itself in order to squeeze through tiny capillaries. And if the red blood cell membrane is damaged or lacking in one of these proteins in a condition like hereditary spherocytosis, then you don't get this nice concave membrane. By concave membrane, you get a normal ball shape or sphere, and the cells don't have this pale center. All right, so hemoglobin is the measurement that we use most of the time to look at for anemia in the lab. The ranges are slightly different for men and women, but too low hemoglobin is obviously anemia, and anemia can be symptomatic, but it depends a little bit on how quickly it's developed. Slow onset anemia, such as that you see in vitamin B12 deficiency, can really get quite low, even into the 30s or 40s, before the patient presents with symptoms. And the symptoms of anemia, well, we know paleness, pallor, tiredness, shortness of breath. Patients often complain they can't go upstairs as well as they could, or they can't go up hills. Headaches, palpitations and fast heart rates as the blood is forced around the body more quickly in order to compensate for a reduced number of red cells, and that can, and also dizziness and fainting, as that can be a sign of anemia. And occasionally, when the patient has ischemic heart disease, so the arteries are not working so well in the heart, then having a lower number of oxygen-carrying red cells can lead to the cardiac, the muscle being lower in oxygen, and that can cause chest pain. So to start with, when we look at the red cells and we're thinking about anemia, the thing that we look at is the red cell indices. This is before we've done hematinics or any other tests. We can see whether the mean cell volume or the mean cell hemoglobin are changed, and this can give us a big clue as to the cause of the anemia. So in a patient with a low mean cell volume, that's called a microcytic anemia. They can also have a low mean cell hemoglobin, or MCH, and that's called a hypochromic anemia. So one of the sort of presentations can be a hypochromic microcytic anemia, and by far the most common cause of that is iron deficiency. The cells are smaller and they are lacking in hemoglobin. That's a clue to this is to look back at previous results of the patient. If they've had previous blood tests done and there's been a downward trend in the MCV and the MCH, and this is tracked with the downward trend in the hemoglobin, then that tells you that the patient has been gradually losing iron and becoming iron deficient. If the patient has always had a mild anemia with a low MCV and a low MCH, and has always had that as far back as you can see, Think maybe this might be a hemoglobinopathy, particularly if the patient has a um, is from a part of the world such as the Middle East or uh, North Africa or the Southeast Asia, where hemoglobinopathies are more common. Then, or usually in those circumstances, there's been a chronic, an unchanged low microcytic hypochromic anemia. The patient might not be that anemic because it's not a progressive disorder, and usually the red blood cells or the red blood cell count (RBCs) are raised because the patient has got plenty of iron. They're just not making very well hemoglobinized red cells. Chronic diseases and rarely myelodysplasia, a form of myelodysplasia called sideroblastic anemia, can lead to a low MCV and a low MCH, and very rarely, thankfully, these days, lead poisoning. We see a lot of normochromic normocytic anemia, so that's cells that are normal size and shape and normal hemoglobin concentration, but the patient is anemic. And chronic disease or inflammation are probably the commonest causes of that. Bleeding acutely, although the clinical picture should help to distinguish that. To occasionally bone marrow infiltration or aplastic anemia, although the other blood counts, such as the platelets and the white cells, will also be low in that case. And then large cells, macrocytic anemia, often the cause is B12 or folate deficiency, so that'd be the first thing to check. Liver disease, alcohol excess, thyroid deficiency, and drugs. Things like hydroxycarbamide, methotrexate are relatively common causes. Okay, so here we have a clinical case. So this is a young woman, 21-year-old, tired all the time. What's the diagnosis? Well, they are anemic. They have a low meter volume. They have a low MCH. So this is a hypochromic microcytic anemia. Their white count is normal, so that we think that this is probably not bone marrow failure. And their platelet count is normal, 530. Actually, it's high, not normal, it's high. That often goes with bleeding, actually. A high platelet count is sort of a compensatory thing. Bleeding, infection, inflammation, all can cause the platelets to be high. And the neutrophils, which are one of the white cells, are normal. Don't worry about the RDW. You're often not given it. And the red blood cell count here, we can see, is low. So this is looking less likely to be a hemoglobinopathy, more likely to be iron deficiency anemia. So that's the most likely cause. What are we going to do to investigate further? Well, we want to know what the ferritin is, because that is the molecule which stores iron and is low in iron deficiency anemia. Remember that the ferritin is sometimes elevated a little bit when you've got inflammation or infection going on, because it's an acute phase protein, so it's sometimes a little bit unreliable. We could do a blood film that will show morphologically iron deficiency, although it's usually not necessary. And then we need to think about the cause, because iron deficiency anemia is not the diagnosis. It is a reflection of another disorder. In a young female of menstrual age, then heavy periods, menorrhagia might be the cause, GI bleeding, some sort of blood loss, rarely dietary deficiency causes iron deficiency. How are we going to treat it? Oral iron is usually adequate, and it's safe, and it's economical. But sometimes 3 times a day oral pyrosulfate is not well tolerated. We can try using IV iron or referring for IV iron if it really isn't very well tolerated, although it's more expensive and it's more invasive, and usually oral is adequate. And then think about treating the cause. So sometimes if it's bleeding, maybe the menorrhagia needs to be brought under control, whatever. But that's always something to think about, particularly in men. Men, it's not normal for them to be iron deficient. And anemia due to iron deficiency is not normal in male, because we don't lose blood in the same way. So think about malignancy, think about gastrointestinal pathology, definitely need to be investigated. This is a blood film from someone with iron deficiency anemia on the left, compared with a normal blood film on the right. And as you can see in the normal film, you've got this nice thick hemoglobinized red cell here, which is of normal size, and they're all uniform shapes. On the left here, we have an iron deficiency picture with pale red blood cells, not they're not all like that. Some of them are normal, but most of them are quite pale and quite small. And that's what you classically see in iron deficiency. You also see something called pencil cells, which are these sort of cigar-shaped, elongated cells. And the whole film just looks a little bit scruffy. Okay, so we're going to move on. We're moving on to the hematocrit. So the hematocrit is the amount of red blood cells in the sample. So we allow the test tube of blood to stand, or we spin it down so that the heavy stuff goes to the bottom, the light stuff stays at the top. And we have a normal sample on the left here, and the yellow stuff is the plasma, the liquid. The red cells are heavy because they've got iron in them, and they drop to the bottom. And the percentage of the whole tube which is taken up by the red cells is called the hematocrit. So we're looking here at about 45%, I would say, of that tube is red cells. And we have the range here, 36 to 0.44, slightly lower in females compared with males. Now, there's lots of causes for an elevated hematocrit, and this would be an elevated hematocrit. And try and forget about these numbers here, because this is the first blood film I showed you from earlier, and this is a pancytopenic patient, so these numbers are not relevant to this diagram. But in this case, we have polycythemia, so you've got too many red cells. So the column of red cells is high, and this is what's called an absolute polycythemia. So you have what's happened here is that the amount of plasma in the sample has not been reduced, but the amount of red cells has increased. When you have a relative polycythemia, you actually it's high. It's high compared with the amount of plasma. That's because the amount of plasma has reduced, such as is seen in diuretic use dehydrational states. The actual amount of red cells hasn't really changed. It's just the plasma which has changed. Whereas in absolute, the red cells have changed, the plasma hasn't changed. Now, the hematocrit is also known as the packed cell volume. The normal range I've placed here. For males and females, slightly different, ever so slightly different. And it's a particularly useful, it can be a useful measure of the patient's hydration status in clinical context. But also, when I'm thinking about polycythemia, I want to rule out primary polycythemia. So the causes of a raised packed cell volume, increased red cells, it can be primary or secondary. Now, primary polycythemia is where you've got a mutation in the bone marrow, usually the JAK2 gene mutation, seen in 95% of cases, which causes an overproduction of red blood cells. And to have that, you have to have 2 raised hematocrits over 6 weeks apart, with no other obvious cause. And we think about doing a JAK2 mutation in those cases. And that can be done in the genetics laboratory. And a secondary polycythemia is seen in, as I say, in dehydrational states, sometimes in chronically hypoxic states. So if there is an unexplained raised hematocrit over 6 weeks in duration, we would think about doing a JAK2 mutation gene assessment. And if that was negative, we would be looking for secondary causes as well. Sometimes erythropoietin secreting tumors can cause a secondary polycythemia, and that we sometimes see, so we always tend to check the erythropoietin level as well. Okay, we have another clinical case. This is a 32-year-old man with marked fatigue and breathlessness. He has a history of vitiligo and hyperthyroidism, some autoimmune disorders there. Okay, so he's very anemic, 51 grams per litre. And he's not that, I would say he's not that symptomatic for such a low hemoglobin. So that tells me that this might be something that's come on quite insidiously, quite slowly. He's got a very marked macrocytosis, so very big cells. So these are, and they're a little bit, the MCH is a little bit raised, but I wouldn't read too much into that. They are macrocytic anemic cells. The white count is slightly low, okay, but that can be and the platelet count is slightly low, but that can be sometimes seen in this particular disorder. So I would be thinking in a young person this age, particularly with an autoimmune history, I'd be thinking maybe this is pernicious anemia, where you have an antibody which is stopping you from absorbing B12. Okay, so B12 folate deficiency is a common cause in this situation, and that will be what you would want to check. Okay, so we check the B12. We think about pernicious anemia as a possibility. That's an anti-intrinsic factor antibody disorder. Bone marrow failure is possible because you can see the rest of the blood cells are also low, and that is possible. But the patient's young, so myelodysplasia is probably unlikely. I would say it's definitely on the list, but second or third. And then we'd be thinking about medications. Sometimes if the patient's on a long-term anti-metabolite, such as methotrexate or hydroxycarbamide, that could cause this sort of picture. But the clinical history would tell us this. So we want the hematinics, we want a blood film. A bone marrow is not usually necessary if it's B12 folate deficiency. Megaloblastic anemia, so that's B12 or folate deficiency, and that's what is under that umbrella term of megaloblastic anemia. The cells are big. If you look at the bone marrow, the precursor cells are big, which is why it's called megaloblastic. And it develops insidiously, and it often causes profound anemia before it's detected. And we think about B12. B12 stores take a long time to deplete. Veganism is sometimes responsible because there's not much B12 in things other than animal products, although it can be replaced by supplements. And poor absorption, pernicious anemia, where you have an anti-intrinsic factor antibody, is one of the causes. Folic acid is also something that's definitely worth checking. Dietary inadequacy is common. Sometimes alcohol and liver disease, particularly that goes hand in hand with a poor diet sometimes. Pregnancy is really important to be thinking about folic acid because it's an absolute requirement for pregnant women, particularly in that first trimester, to stop neural tube defects. Yeah, and some drugs which block metabolism. Okay. So features of megaloblastic anemia. You get obviously get anemia, macrocytic anemia, slightly raised LDH due to red cell breakdown, what's sometimes described as lemon yellow jaundice, which is supposed to be due to precursor red cell breakdown. Sometimes they can have a lower platelets and neutrophils. And because it's not just the red cells that need B12, you need B12 for your epithelial cells and for your cardiac myocytes and for your nerve cells. You can have some of the other symptoms and signs, such as soreness of the mouth and soreness of the tongue, and enlarge, and the patient can have, very rarely, thankfully these days, B12 deficiency can cause subacute degeneration of the cord. Yeah, so these are rare symptoms nowadays, thankfully, now that we have decent dietary replacements. The really important thing to do is replace, if you have a B12 or folate deficiency, is to replace both simultaneously. Because particularly if you're lacking in one and you replace that one, you can sometimes burn off the other one and reuse up the other one very quickly. And so it's important to replace both if you have a deficiency. Folate is replaced orally. It's very safe and economical drug to give once a day, 5 milligrams. And vitamin B12, if it's deficient, is usually replaced intramuscularly. We try to avoid blood transfusions with B12 deficiency because the cardiac myocytes are a little bit B12 deficient, and there is anecdotal evidence and some cases to suggest that they are more liable to getting cardiac overload from transfusions if they're B12 deficient. Usually, B12 replacement with folate is adequate to recover, and they usually recover quite quickly. And then we think about what the cause is in our young chap, maybe thinking about pernicious anemia, referral to gastroenterology possibly. Okay, so next case. This is a 76-year-old male who is unwell and tired all the time. and short of breath. And on examination, they are jaundiced. They have some lymph gland enlargement. They have mild splenomegaly. Okay, let's have a look at their full blood count. So they are anemic, 80 grams per deciliter, sorry. They have a slight macrocytosis, actually, so their their cells are a little bit large. Their MCH is pretty normal, so normochromic macrocytic. Hematocrit is just a kind of reflection of their anemia, so wouldn't worry too much about hematocrit. They have a raised white count, and therefore let's look at the differentials. Their neutrophils are normal. Now, I haven't given you the full white cell differential here, but let's say that they actually have a lymphocytosis in this case. Platelet count is normal. Now, you can ask the lab, and some labs will give it to you anyway, for a reticulocyte count. Reticulocytes are the baby red blood cells that are coming, the new ones coming into the circulation. And in a patient who has a healthy-ish bone marrow, is able to make red blood cells, but is losing them for some reason, either through bleeding or consumption of some form, then the reticulocytes will be raised. And in our case, he has got what's called a reticulocytosis. So there is a raised reticulocyte. So he's making lots of red blood cells. He's trying to compensate for this anemia. So there's a loss of red cells somewhere along the line. He's jaundiced, we know, and his bilirubin reflects that. And his LDH is raised. So LDH is an intracellular enzyme, which is usually released when there's lots of cell breakdown. So necrosis, surgery, sometimes infection, trauma can all raise your LDH, but also classically hemolytic anemia causes a raised LDH. So this all looks to me like hemolytic anemia. You've got a brisk reticulocytosis, you have macrocytic anemia, you have bilirubin is raised, so red cells have got lots of bilirubin in them, so that's being broken down and released, and also red cell breakdown is causing the LDH to be raised. So I'd be thinking hemolytic anemia in this case. Okay, there's some very short, small font type here, which is just basically just reiterating what I've just said. Now, if we're thinking this is hemolytic anemia, we want several things. We want a blood film, because a blood film will tell us if there are spherocytes. Remember, the red cell membrane is damaged by autoimmune hemolytic anemia. Autoimmune hemolytic anemia, the red cells are coated in antibody. They are damaged by macrophages. They become spherical, and that is a good clue to it in the blood. And if this is that would be what's called an extravascular autoimmune hemolytic anemia. So it's happening in the liver and the spleen, outside of the blood vessels, really. In an intravascular hemolytic anemia, so this is happening in the blood vessels, which is also known as microangiopathic, in the small blood vessels, usually you have fibrin deposition, so clot deposition, so causing a mesh of clot in the blood vessels, which, as the red cells go through the mesh, they are damaged, and it forms not spherocytes but fragments, red cell fragments, and they can be seen on the blood film as well. So let's look at some investigation. So we're thinking hemolysis, and we've asked for the rest of our hemolytic screen. So in a hemolytic screen, what we want is a full blood count, obviously, a blood film to look for spherocytes or fragments. In this case, we've got spherocytes. LDH to look for red cell breakdown. Bilirubin to look for red cell breakdown. What we also ask for is a direct antiglobulin test, or DAT, which used to be called a direct Coombs test. And that's to see if there's antibody stuck on the red cells. That will tell us that this is autoimmune hemolytic anemia. And finally, something called haptoglobins. Haptoglobins are proteins in the blood which will mop up any free hemoglobin. Free hemoglobin is not wanted in the blood. It's a little bit toxic. So your haptoglobins absorb it, mop it up. And if they are diminished or absent, that tells us that there's hemolysis going on. And it doesn't take long for you to exhaust your haptoglobins. They're actually a good marker, because the rest of these are not all that specific. LDH could be high in infection or trauma or surgery or necrosis. Reticulocytes could be high if they're just trying to replace red cells, even in bleeding. Bilirubin can be high for lots of reasons, as you know. So haptoglobins are quite sensitive and specific for hemolysis. And then the DAT, the direct antiglobulin test, which used to be known as the direct Coombs test. And it can be positive for warm, so that's IgG, if there's IgG stuck to the red blood cells, or for cold, so that's C3d, which is a bit of complement stuck to the red blood cells. And sometimes it's positive for both in a mixed picture. And sometimes it's positive when there isn't any hemolysis going on, about 1% of tests if you look at them epidemiologically. People get really confused by the direct antiglobulin test, but basically what you're doing is you're taking the patient's red blood cells, and the question we're asking is, have those red blood cells got antibodies stuck to them, either IgG or have they got a bit of complement stuck to them, C3d? So what you do is you take a tube of the red blood cells, you resuspend it in saline to get rid of all the plasma and any antibodies that's there. You then add an antiglobulin antibody. So this is an antibody which is targeted against the IgG that's stuck to the red blood cells and against complement. So usually we add a polyspecific antibody. So the antibody is added to the cells, and then if there is IgG, let's say, for example, stuck to those red blood cells, the antibody that we've added will cross-link the IgG with other cells and cause the sample to agglutinate. Sorry, not hemolyze, agglutinate, and that is a positive result. So if there's agglutination after you've added the antibody, that is a positive result. And then we can go back and say, well, is this IgG, anti-IgG, or is this C3d? And so we can do a specific, and then add a specific antibody against IgG and a specific antibody against C3d. And if we get a positive result with one or the other, we know that this is that the patient has IgG or C3d stuck to their cells. That's important because in warm autoimmune hemolytic anemia, it's usually IgG positive. And in cold, actually the damage is being done by an IgM, but the IgM doesn't tend to stay on the red cells when they're brought out of the body and sampled. It tends to fall off, and it just tends to leave behind complement C3d. So if it's positive for complement C3d, negative for IgG, is usually a cold picture. Okay, so that's important because it narrows down our differentials as to what the cause of the hemolysis is. So in IgG positive or warm type hemolytic anemia, sometimes it's idiopathic, so there's no underlying obvious cause, but often it's secondary to chronic lymphocytic leukemia or lymphoma or an autoimmune disorder, or sometimes drugs, or post-transplant, but that would be clinically apparent. So if there's nothing clinically apparent, we might go looking then for lymphoma or CLL. And in our case, if you remember, there were lymph glands were raised and there was a bit of splenomegaly, and I would be thinking we should look for an underlying cause. And also this type responds best to steroids and to rituximab therapy. And then a cold type, C3d positive on the DAT, that's often idiopathic, actually, but can be also due to lymphoma, viral infections, mycoplasma infection, and infectious mononucleosis, which is also viral. And also just to note that IgM or cold type tend not to respond that well to steroids. So just to briefly, if the patient had a negative DAT, so there was no antibody stuck to the surface, and the blood film showed fragments, these are fragments of red blood cells or schistocytes, then we'd be thinking about this is intravascular, that the hemolysis is happening inside the red cell, inside the vessels, blood vessels, possibly due to a mesh of fibrin, possibly due to, and there are different causes for this, but DIC, disseminated intravascular coagulopathy, where you have an uncontrolled production of fibrin, which is often related to malignancy or major trauma or sepsis or obstetric problems. Occasionally you can have TTP, which is where you have a lack of a particular um, protein or enzyme which breaks down von Willebrand's factor. And sometimes infections such as E. coli 0157 can cause a hemolytic uremic syndrome, which gives you this picture. And the features, as we've already described, are these fragments, the presence of free hemoglobin in the blood and in the urine. So if you dip the urine, you'll often just come up positive for blood, but it's not blood cells you're detecting, it's free hemoglobin. A negative direct antiglobulin test, raised reticulocytes because they're trying to compensate, raised LDH and bilirubin, and end organ dysfunction because of the presence of these fibrin mesh and these micro clots, microthrombi in small vessels. So small vessels of the kidneys, the brain, the liver can cause renal dysfunction, liver dysfunction, and sometimes neurological impairment. And because this is caused by uncontrolled clotting problems, the fibrinogen is usually consumed, and the other clotting tests can be deranged. Right, so we've come to the end. So when faced with anemia on a full blood count, you should consider, is the mean cell volume low, microcytic? Think about iron deficiency, hemoglobinopathies, and rare causes. Is it normal? Think about chronic disease, inflammation, sometimes acute bleeding. Or is it large? Are the cells large? Think about B12 and folate, some drugs, chronic diseases, alcohol, thyroid, and that will help you to direct your clinical assessment. Is the MCH, mean cell hemoglobin, low? That would tell you that this is probably either an iron deficiency or a hemoglobinopathy, but we remember we're going to be doing our ferritin levels, and we're going to be looking for our red blood cell counts and looking at the previous blood results and the history of the patient. Whoops. Another way of measuring hemoglobin is looking at the hematocrit. We don't tend to use it so much in anemia, but it's useful in polycythemia. And if they've got a raised hematocrit, persistently so for more than 6 weeks, consider secondary causes like dehydration, hypoxia, the use of growth hormones, anabolic steroids. Think about erythropoietin secreting tumors. We can measure the erythropoietin level, remember. And think about, finally, primary causes, polycythemia vera, the JAK2 mutation, which is present in most cases of that. The red cell count can be useful in distinguishing iron deficiency anemia from hemoglobinopathies before we go on to do more formal studies. And the clinical picture, probably the most important thing, is how long have they been anemic? What are the medications? What are the drugs? Are there any clinical features to suggest malignancy or deficiencies in diet or autoimmune disorders, etc. And then we never look at the red blood cells in isolation. We always look at them in context of the other cytopenias. So consider drugs. If all the cells are down, then it may well be a pancytopenia due to drugs or bone marrow failure, infiltration, infection, autoimmune disorders. Okay, so that's the end of this particular presentation. Many thanks for listening. I hope you found it useful. If you have any questions, then please do email in. But otherwise, we'll look forward to seeing you next time.